And so before we get too much into the weeds of some of these studies, I thought it would be interested to look at the history of human body temperature. So classically, what is considered normal body temperature is 98.6 degrees Fahrenheit, or 37 degrees Celsius. Does anybody know where this number comes from? Is there anyone who's brave enough to speak up if they know? So I didn't actually know either. So I looked it up. And so this physician, Karl Wunderlich, he's a German physician in 1851. He took axillary temperatures of about 25,000 patients and then averaged them. That average came out to 98.6. He published that information in 1868, and that officially became normal human core body temperature and persists 150 years later. Now, interestingly, some more recent research from Stanford has actually found that human core body temperature has been steadily decreasing since that time. They have been studying patients. They have over 644,000 patients over time. And they found that actually now the average human core body temperature for females is 97.7, for males is 97.5, with an obvious average of 97.6 degrees Fahrenheit. And their hypothesis is that this is because of a decline in population level inflammation, whether it's from improved sanitation and hygiene practices, or a decrease in certain infections that can cause a chronic inflammatory state. And they specifically mentioned decrease in the prevalence of tuberculosis as a potential cause. And so humans, I think we've all learned this at some point in biology, we are homeotherms like other mammals. And that means that we maintain a core body temperature within a relatively small range. And that body temperature is generally above that of the environment, unless it's August in Louisville, in which it's about the same. And we have to generate our own heat to maintain that body temperature through our metabolism. But even though we do maintain our body temperature within a really small range, there's still known variation by as much as a half a degree from person to person, based on your age, based on the time of day, or your sex assigned at birth. And newborns in particular are special because their metabolism doesn't always do the job to maintain heat or to maintain the body temperature. And they're dependent on other humans to modify their environment to help with that. And so when environmental modifications, skin-to-skin contact, their own metabolism aren't enough, newborns actually have a limited mechanism to generate additional heat. So they have limited muscle bulk and contraction, and so a very limited ability to shiver like older children and adults. And so, when their body temperature starts to fall, they're dependent on non-shivering thermogenesis, which is primarily from the metabolism of brown fat, which they don't have a large store of. And this can cause glycogen store depletions, tissue hypoxia. And so the result of hypothermia can be hypoglycemia and acidosis. So how do we define hypothermia? So there are actually 3 different definitions. So right out of the gate, there is controversy about what even is a hypothermic infant. So the World Health Organization actually divides hypothermia into 3 categories. Mild, which would be 36 to 36.5 degrees Celsius. Moderate, which is 32 to 35.9. And then severe, which is less than 32 degrees Celsius. But I think it's important to note that these categories were actually developed to guide newborn care in the delivery setting in low resource countries, and similarly to dictate the urgency of interventions in some of those low resource settings. So the International Pediatric Sepsis Consensus defines hypothermia as a core body temperature of less than 36. The National Health System in the UK defines core body temperature as less than 35. And these are definitions that are used by Mayo Clinic, Cleveland Clinic, and then everybody's favorite, Wikipedia. And so there is no head-to-head comparison of these three definitions in terms of accuracy. I will say I looked at the sources that were cited in that International Pediatric Sepsis Consensus. The three articles that they cite to come up with this definition are all articles that were, or studies that were done in the 1980s, where they looked at characteristics of afebrile children who were later diagnosed with serious bacterial infection. And they identified 36 degrees Celsius or lower as increased risk for sepsis. And generally speaking, most pediatric research or research on young infants does use this middle definition, this International Pediatric Sepsis Consensus definition of less than 36. And so I mentioned at the beginning, I wondered a lot, is this fear of hypothermia just dogma? Is this just something that I learned and never questioned? But there is actually a pretty wide base of literature that supports an association between hypothermia and mortality. The first person to know this demonstrate this relationship was a Parisian obstetrician who identified that relationship between temperature and mortality risk amongst newborns. And there have been other studies that have shown things similar over the years. But a big criticism of these is that many of them were done in low resource settings and might not be applicable to the US. Many of them were done a long time ago, in the 70s, 80s, and 90s. And so, is there more recent research that continues to support the association of hypothermia and mortality? And so these studies have all been done in the past 5 years, and they've been primarily examining hypothermic infants who present to pediatric emergency departments. Most of them are single center retrospective studies, and I'll talk about most of them in more detail. I do want to point out the fourth study there on the list, I put a little asterisk there. This is actually something that was done here in Louisville in our own ED by Sam Lucrezia. I hope I said that right. And Adam, who's one of our PDM fellows, and Adam Isaacoff and a team of a number of other physicians who helped with this research. And Sam is going to be presenting this data at the AAP meeting in the fall. I don't want to steal her thunder, but her team was kind enough to share her abstracts, so I will talk a little bit about what they found. The other thing that I'll mention about these studies is that, fortunately for our patients, serious bacterial infection is a relatively rare outcome. That makes it tough to find a lot of statistical significance in these studies, but it does allow for a really granular, detailed look at the patient characteristics. So we can get a lot of rich information from some of the individual patients in some of these studies. So as you look, most of them found that the percentage of hypothermic infants who present to the ED, somewhere between 2 to 3% of them are ultimately diagnosed with serious bacterial infection, compared to the typical number cited in the literature around febrile infants is about 9 to 10%. So the incidence of SBI in hypothermic infants is lower than that of febrile infants. Now, if you look towards the bottom, Ram Gopal, I hope I say that name right, did find a 7% rate of SBI. But I'm giving this study a little bit of the side eye for the following reason. So this was a FIS database study, and records were pulled based on ICD-10 codes. And this study had an unusually high rate of bacteremia. There were 2.5 times as many cases of bacteremia as there were UTI in this sample. And that raises a red flag for me. I have never seen those kinds of numbers anywhere else. And so I'm suspicious that a lot of contaminated blood cultures were coded as bacteremia when in fact they weren't true infection. And the Wood study also found a slightly higher percentage of hypothermic infants with SPI. This was one of the smaller sample size studies compared to some of the others that I'll talk about today, which may explain a slightly higher number. But this 2 to 3% is consistent with some of the more historical literature that I referenced earlier in terms of percentage of hypothermic infants later diagnosed with serious bacterial infection. So the first question that I was really interested in answering is, does age matter? And I'm not just talking about age less than 60 days. I'm talking about 0 to 7 days, 14 days, 21 days. Because with febrile infants and serious bacterial illness, age is everything. Or, well, it's not everything, but it's really important. It's the first branch point in our decision-making tree for a febrile infant. And so I was really curious, does age matter in the same way with hypothermic infants? So one really interesting study that examines that question, this is not the FIS database study that Ram Gopal did, but a different study. He did a retrospective single center study at a large urban academic children's hospital. They looked at infants under 60 days of age who presented to the emergency department with a rectal temperature of less than 36 and got either a full or partial sepsis workup. The primary outcomes that they looked at were bacteremia, meningitis, and urinary tract infection, and they secondarily looked at HSV infection and death. And they examined their data in 4 different age groups. So they looked at infants who were 0 to 14 days, 15 to 28 days, 29 to 42, and 43 to 60 days of age. They overall had 447 infants that they identified. 360 of them were included. And they ultimately found 10 with serious bacterial infection. And so we're going to put up another poll to the group. Which age group do you think had the highest rate of serious bacterial infection? All right. So the majority of our respondents indicated they think that the 0 to 14 day age group had the highest rate of SBI, followed a relatively close second to infants in the 15 to 28 day age range. And it is the 15 to 28 day age range actually had the highest rate of serious bacterial infection. The infants in this group, about 9% of hypothermic infants in this age group had a serious bacterial infection, compared to 2.2% in the youngest age group. And the odds ratio for this was actually 4.39. And this was really surprising to me, and it was surprising to at least half of you, because it is the opposite of what we know about febrile infants, where the risk of SBI actually increases with lower age. And so this Ram Gopal study is one of the largest to date, looking at hypothermic infants presenting to the emergency department and SBI, but it's just one study. So what do some of these other studies say? Is there a similar pattern? So another study, again, a very similar, another pediatric emergency department at an academic center. They looked at infants who presented to the emergency department with an initial rectal temperature less than 36.5. So their definition of hypothermia is a little bit broader. They looked at patients with either a full or partial SBI evaluation. And their primary outcome was looking at a culture growing a pathogenic organism in the blood, urine, or CSF. And I'll also mention that they also defined urinary tract infection as 10 to 50,000 colony-forming units and urine culture, which is actually a more broad definition than what we typically include, which would be greater than 50,000 CFU. So what in this study was they had 487 hypothermic infants. There were 104 who had either a full or a partial SBI evaluation, and they found 9 with serious bacterial infection within that group. And so what was the mean age for these hypothermic infants diagnosed with SBI? They also found an older age range. Their mean age was 18 days, and they found that increased age was the only statistically significant factor that identified serious bacterial infection compared to hypothermic infants who did not have serious bacterial infection. And so if you look at some of these other studies that I mentioned at the very beginning, it wasn't just these two. All of these studies actually had a mean age of serious bacterial infection greater than 7 days, so outside of the first week of life. And so I think that, you know, we can conclude is that yes, age matters, maybe not the way at least that I thought. And so hypothermia is much more likely to be pathologic as age increases in young infants. And hypothermic infants greater than 14 days of age have rates of serious bacterial infection similar to that of febrile infants. And so I think this is useful in thinking through some of these patients and decision making. But these graphs, and it's not necessarily important that you can see every single detail. I know that some of them are small. So the graphs are the age distributions in each of these studies of these infants who are presenting with hypothermia. And the point of this is that the overwhelming majority of patients who are presenting to the ED are in that first week of life. And so hypothermia, while it may not be pathologic, is common. And this has been demonstrated in another study that looked at 200 healthy term infants. And they stayed with these infants in the newborn nursery and took axillary temperatures at various points in care over 72 hours after feeding, after bathing, after nursing assessments. And they found the average temp at birth was right at 36.5 degrees Celsius. And they found that temps often dropped after various points of care. It dropped 0.2 degrees Celsius after bathing specifically. And they found that 20% of all temperatures taken were below 36.3. They did not explain why they picked 36.3 as their threshold. About a quarter of these healthy infants had blood cultures done. There were no positive cultures, and there were no readmissions after discharge for those who were not cultured. And so they just confirmed that hypothermia can be found in healthy term infants without other signs of illness. But so, you know, if we have, if hypothermia is common in the first week of life, how do we identify those patients that might have something serious going on? And so the next question that I sought to answer is, does the degree of hypothermia matter? How cold is too cold? So not every study looked at this. These are the 4 who actually compared temperatures for those infants that had serious bacterial infection and compared them to infants who did not. And so a quick perusal of these temperatures, you can see that there was not a huge difference in the infants in these studies among those who had serious bacterial infection and those who did not. Only one of these studies actually found a statistically significant difference between the arrival temperature of infants who have had serious bacterial infection compared to infants who had not. They did note that 80% of infants who had serious pathology, and this includes non-infectious serious pathology, had a temperature that was less than 34.4 degrees Celsius. But if you remove infants in these studies that had UTI only, and only look at the children who had invasive bacterial infections, meaning bacteremia and meningitis, those arrival temperatures do go down. And this is just my research, I guess, and just interesting trend that I noted, taking out those patients with UTI. So there's no ways to statistically give this any value other than I think it's an interesting trend. And so does degree of hypothermia matter? I don't know. I think it makes intuitive sense that the lower the temperature, the more likely there is serious pathology. But milder hypothermia does not necessarily exclude serious illness. So what about other symptoms? Are there other things that might help us identify those sick patients in that first week of life with hypothermia? So these are, again, studies mostly in the emergency department who, did take a very specific look at each individual infant who presented with hypothermia and had serious bacterial infection. And I should note that none of the hypothermic infants in any of these studies had isolated hypothermia. All of them had other symptoms, exam findings, or labs that might have been clues. So a study done by Catherine Kazmaier, again in the emergency department, in her study, they found 3 hypothermic infants with serious bacterial infection. All 3 of them presented with poor feeding, lethargy, respiratory distress, and 2 of them presented with apnea. Michelle Perry and her group found 9 infants with serious bacterial infection. 5 of those 9 also presented with a chief complaint of poor feeding, 1 with lethargy, 1 with respiratory distress, and 3 with cyanosis. And these are chief complaints. So these are things that were noted by family members. And then this bottom study, I have an asterisk here, Wang and her group, they actually looked at afebrile infants. So they included normothermic and hypothermic infants. They did not separate out their data on hypothermic versus normothermic infants. So there's a little bit of a difference there. But of the 78 afebrile infants with serious bacterial infection, 48% presented with poor feeding, 26% presented with lethargy, or 26 presented with lethargy. And so all in, if you combine this data from all of these studies, poor feeding is a very common complaint for infants, hypothermic infants, who were ultimately diagnosed with a serious infection. Now, what about past medical history? The biggest thing that seems to be looked at is a history of prematurity. And so in some of these similar studies, they looked at which infants had a gestation at birth less than 37 weeks. And it was a little more than half across 3 different studies, which was surprising to me. I was expecting to find a history of prematurity more commonly because we know that premature infants are at risk for hypothermia. We also know that infants who are premature are at risk for serious bacterial infection. But at least in these studies of infants who presented to the ED, it was only about half of them had a history of prematurity. And there were a fair number who also had NICU stays for other reasons. So what about the exam? What are some things that stand out in an physical exam amongst these infants that have hypothermic infants that have serious bacterial infection? So again, looking at some of these similar studies, Kazmaier, Perry, and Wood, 71% of these infants were documented as ill-appearing by the physician who saw them first. Lethargy, apnea, hepatomegaly, and delayed cap refill were also noted in a number of these infants. But ill-appearing really is the characteristic on exam that stands out. And so I was interested to see, what does that look like if you remove the patients with UTI? So in the Perry study, 2 of the 3 infants that were noted to be well-appearing had UTI. And so if you take those infants out, 8 out of 9 of those infants, again, were noted to be ill-appearing by physicians. And this is actually pretty consistent with an old study that I found. This was done in 1985, where they looked at the predictive value of the physician kind of assessment of sick or not sick. And it turns out that pediatricians are actually pretty good at this. 80% of children that were described as ill appearing by their pediatrician were later diagnosed with a serious illness. And only 2% of children that were described as well appearing by their pediatrician were later diagnosed with a serious illness. And so, like in these emergency department studies, this is consistent. Pediatricians are actually really good at identifying sick babies. And on a similar note, these are some studies that I referenced before. These are infants who presented with hypothermia to the emergency departments. And you'll notice in 2 of these studies, so, in this Perry study, there were 487 initially identified, 73 that were excluded for miscellaneous reasons. So their sample size was 414 included. 310 of them had no SBI evaluation at all. And Kazmaier, a slightly smaller but similar study, initially had 147 infants. 30 were excluded because they didn't have a rectal temperature. So of their 116 infants that they included, 83, again, had no serious bacterial infection evaluation at all. And each of these studies comment in their discussion that they are the only children's hospital and the only pediatric EDs in their respective communities. And so it was unlikely that a child with SBI would be admitted anywhere else in their community. And in both cases, they had 0 return ED visits and 0 readmissions for infants with serious bacterial infection. And so again, I think it supports, and this is true actually not just for these 2 studies, but for some of the others. Now, it was a smaller percentage that were excluded for no workup, but I think this just further supports that we as pediatricians should trust our exam and our judgment, because we're actually really good at identifying patients who ultimately will have serious pathology. So what about labs? Can labs help us with these hypothermic infants and again identify those at risk for serious bacterial infection? The labs most studied are white count and ANC. In only one study, Ram Gopal actually found that infants with a higher ANC, hypothermic infants with SBI had a higher ANC than those in their study without. I was really curious about things like procalcitonin, for example, and it does appear this value is being used to kind of track progress in therapeutic hypothermia, but I did not find any literature on this lab value specifically in identifying SBI in hypothermic infants the way it might with febrile infants. And so as you look at some of these factors that might help us, we have, definitely we need to take seriously hypothermia in an infant outside of 7 days of life. If there's a history of poor feeding or lethargy, and if they're ill appearing on exam, that patient deserves your attention. It's a little bit of a toss-up in terms of history of prematurity and the degree of hypothermia, but it doesn't look like labs are particularly helpful in identifying concerning infants. And so I think the big elephant in the room is HSV. And I think if I were to ask my partners in hospital medicine and probably my friends in the ED and in primary care as well, what weighs heaviest when you're considering hypothermic infants? It's missing HSV as the diagnosis. And there are some studies that have estimated that as high as 1% of all hypothermic infants were positive for HSV. And when you consider the morbidity and mortality of HSV infection, that can be a really scary number. And so for these next couple slides, I want to make sure to credit Jackson Williams, one of my hospitalist partners. He has a really keen interest in HSV infection in young infants, hypothermic infants, and he really did an enormous amount of work contributing almost entirely to these next few slides. And so if you look at, again, this is a combination of a number of studies over time that have looked at temperature and patients who were later diagnosed with HSV infection. And this is all 3 types of HSV infection: SEM disease, disseminated HSV, and HSV encephalitis. And if you'll notice, in the studies that actually did differentiate infants within temperature, hypothermia, normothermic, and febrile infants, about 9% of those infants presented with lower temperatures, which is quite a bit lower actually than normothermia and fever. If you just look at the infants that were diagnosed with disseminated HSV, a slightly higher percentage of those infants did present with hypothermia, but it's still about 12%. So it is still more common to be febrile or even hypothermic if an infant is presenting with HSV. There are some cohort comparison studies that actually looked at differences between infants who were hypothermic versus infants who were not. And so this is a very interesting study that was done at Texas Children's Hospital, where they just looked at all admissions under 28 days. And they divided all of those admissions, about 5,800 unique infants, and divided them into a febrile group, normothermic group, and hypothermic group. And then there was, of course, a group with missing temperatures. And they looked at what were their reasons for admission. And they found that 2 of those 187 hypothermic infants were ultimately diagnosed with HSV. Now, there were infants with HSV in those other groups. They found 10 infants out of these 5,000 admissions, nearly 6,000 admissions, I should say. And they described how those infants presented. And so if you look at the infants who were hypothermic and were later diagnosed with HSV, they were outside the first 7 days of life. They did have pretty significant hypothermia. They had temps below 34. And their chief complaint was actually respiratory distress rather than hypothermia. Cruz and his cohorts in 2018 did a retrospective cross-sectional review. This was across 23 centers. They looked at all infants who were less than 60 days old, who were admitted from an emergency department across 23 centers who had CSF studies for whatever reason. Out of that group, 26,000 infants, they found 112 that were positive for HSV in their studies. The median age of those infants was 14 days, and 5 of those infants presented with hypothermia. And so looking at HSV in the hypothermic infants in these other studies that I've been referencing all along, across all of these studies, there were 786 infants that were examined. 5 of them were diagnosed with any form of HSV. Of those 5, 2 of them were disseminated and 3 had positive swabs. I should mention that in 3 of those positive swabs, they did not clinically have signs or symptoms of HSV. Of the 2 that were disseminated, they were also 9 to 10 days of age, a little bit older. And this is actually pretty consistent with, again, some slightly older studies that looked at the association between clinical and lab features for neonates with HSV and those without. And they actually found that maternal fever during delivery is the thing that with the highest odds ratio for having culture-proven neonatal HSV compared to those without. There have been other studies that have looked at other signs and symptoms of infants who present HSV, and you'll see that hypothermia is definitely there. But you'll also see that 82% of infants with disseminated HSV were noted to be critically ill in admission. You'll also see poor feeding, another pattern. 82% of those infants presented with poor feeding as well. And so a lot of the features that we were worrying about amongst all hypothermic infants are still seen and noted for patients who are hypothermic and later diagnosed with HSV. And so this is still a tough question. I don't know that I necessarily have a great answer, but hypothermia is not necessarily sensitive or specific to HSV. And I did not see, as I mentioned, isolated hypothermia in an otherwise well-appearing child there isn't a lot of evidence that that is a common presentation of patients with HSV. But of course, we know that delayed acyclovir is associated with higher morbidity and mortality. And so this is still a really tough question when considering these hypothermic infants. And so I've spent almost this entire time talking about infections as a serious pathology, primarily because this is the most studied. In some of these studies, they did find other non-infectious abnormalities in patients who presented with hypothermia. It was less common, but they were present. And so when they did, they often found metabolic disorders, congenital brain abnormalities. There's one tracheoesophageal fistula and one patient with a cardiomyopathy. But that is really the extent of research in hypothermia and non-infectious serious pathology in young infants. Now, I was also really interested in what is the data in non-ED settings. You know, I mentioned before, there were lots of infants who are discharged home with no workup, and to the knowledge of their study teams, those patients did not return. So what about those patients that never go to the emergency department? They're seen in the primary care setting. I suspect there's a large number of these patients who are going to their pediatrician, appropriately judged as well appearing, who don't get a workup and ultimately do well. But this slide is blank, and it will remain blank because I could not find anything really looking at patients presenting with hypothermia in the primary care office setting. And I think this could be an interesting question and an avenue for further study. What happens to those hypothermic infants that don't end up in the emergency department, perhaps with integration and now a large network of primary care and pediatric offices? Is this a question that we could look at here? What about applying risk criteria for febrile infants to hypothermic infants? There was one study mentioned very much in passing that they applied the Rochester criteria, which have been used for febrile infants, to these hypothermic infants. And again, it was very much a fleeting passing statement that might have been thrown in after because a reviewer suggested it. But they did say that the Rochester criteria accurately identified hypothermic infants with SBI as well. And what about labs like procalcitonin that we're using very commonly now that are part of our new febrile infant guidelines? Are those useful labs to predict serious bacterial infants in these? And I'll mention that Adam Isaacoff and Sam Lucrezia and the team mentioned that we may potentially be participating in a future research network study. And if any of those people are here on the call and might be willing to comment on that, that would be awesome. So in summary, hypothermia outside the first week of life is definitely more concerning. Patients who present with poor feeding, ill appearance, also are more likely to have pathology. Hypothermia is not necessarily sensitive or specific for HSV, but certainly can be part of the presentation for infants with HSV. And like so many other decisions we make in medicine, a lot of these decisions around these infants come down to the question of how much risk can you live with as a physician. So I want to acknowledge, as I mentioned, Jackson Williams for his work and contributions to the discussion around HSV, Adam Isaacoff, Sam Lucrezia, and their team of people who have looked at this question, Vanilla Ice for his lyrics that I used today and a catchy title, and then I'm told I had to also credit David Bowie and Queen for the beat in the song. And so I'm happy to share my references for anyone who is interested and open up for any questions or discussion. All right, so I'm looking through some of the chat. It sounds like turnaround time for the HSV surface PCRs will be sooner. And I certainly was not intending to throw anyone in micro under the bus, just to highlight just the difficulty with some of these decisions.
Sarah, sorry, it's Dr. Marshall. So thanks for this talk. While you were talking about this with the long turnaround time, which clearly is the problem, I knew that they were working towards sending these specimens out to U of L, and I texted Alan, and he said, yes, they are going to U of L, 48-hour turnaround, 7 days a week. And then after I put that in the chat, he said, well, actually, they're still going to ARUP. But he's going to problem solve on that. And the intent is for these swabs to go to U of L with a 48-hour turnaround time. So I didn't mean to confuse anyone, but that is what should be happening soon.
Yeah, so Dr. Roberts was asking the question around environmental temperatures in infants who might have exposure prior to presentation. So temperatures in the home, winter versus summer. And so presentation for hypothermia is more common in cooler months in the fall and winter, but it is actually more evenly distributed than you would think. And so, and actually the most recent study, so it was actually the FIS database study that I referenced, it was more common, hypothermia was more common in fall months. Now they didn't delineate what they defined as fall, like which months they included. And their hypothesis was actually that in winter, people actually might be paying more attention to bundling. They have the heat on in their homes, whereas in the fall, temperatures may drop, particularly at night, and people just might pay less attention to those environmental modifications in those fall months. But yes, historically, presentation to the ED for hypothermia is more common in cooler months. And so Dr. Schwenk was asking, for our ED folks, do we know, is there a commonly used temperature cutoff for hypothermia? And I have a feeling that this is variable and something that it does differ from physician to physician. I will say that Adam Isaacoff and his team used 36 as the cutoff in the study that they did and in their abstract. Yep, and he's confirming. So Dr. Schickler, so that's a really interesting question. So the interplay of hypothermia and hyperbilirubinemia is interesting. And so the most common associated diagnosis with hypothermia, the most common discharge diagnosis for those infants is hyperbilirubinemia. And the authors, and these are their words, not mine, said that was likely due to the, quote, aggressive identification and management of infants with hyperbilirubinemia, end quote. But I do know that it can be kind of a common criticism, I guess, of our current hyperbilirubinemia guidelines is that it can lead to increased evaluation and testing. And I know there are new hyperbili guidelines coming out. But I did not specifically look at that question in terms of hypothermia with kernicterus, although intuitively it makes sense. Yeah, so Dr. Hurt, a lot of patients that are referred to the ED, are coming from primary care. So, is checking a temperature high yield or not? That's a great question that I actually don't know that I have the answer to.
Well, I'll comment. You've got to think about the pretest probability, right? So what is the probability that a well 1 week old coming in for a well child check who is found to have a low temperature just happens to have come at the right time on the right day at the moment when he was becoming septic, and we just happened to pick it up by a random temperature on a well child check. Seems really, really, really unlikely. So it makes you wonder, why do we check their temperature? I think Jackson could comment on that because I know he's been really interested in this question.
Yeah, and I agree. You know, I don't know that there's a good answer. Our data suggests that those isolated temperatures without other risk factors probably aren't too worrisome, but the challenge is also sometimes these kids are a little jaundiced. Maybe they're not feeding the best, and that may be contributing to low temperature as well too. So I think it's really tough. I do like, Sarah, that you mentioned too the risk tolerance part of all this as well. And I was interested in the new febrile guidelines that just came out 2 or 3 weeks ago, that they have a whole section on risk tolerance and basically stating, yeah, if you have a kid with a high white count and positive CSF, it's a no-brainer, pun intended. But beyond that, it's really hard to figure out how much risk you're willing to accept, and that perhaps it should even be some shared decision making between parents and providers.
And Dr. Langford asked the question, what's the most appropriate route? And I should say, and actually a lot of these studies, at least ED studies, they actually excluded infants who had axillary temperatures and only included rectal. And so rectal is the most appropriate way to obtain core body temperature. And that healthy infant study, those were axillary temperatures as well, but rectal is the most appropriate route.
So Sarah, we know that that's not what's happening in a lot of practices, and so I would turn the question back to Sheridan and ask, what do we do as primary care doctors in terms of advising parents how to take temperatures at home, and also how we're doing it in the offices? I can't tell you how many times we see kids referred to ID clinic because they're having, quote, persistent fevers, when they're in fact getting the forehead thing or the ear thing and not actually a core body temperature. So comments from our frontline primary caretakers? Sorry, I'm needed on the bridge.
I think my experience with our NCMG clinics is that they do teach rectal. It looks like some can't necessarily access the microphone. I certainly know that that's what I was taught in my training, and I know that is, I do believe that is the practice within our primary care, is teaching rectal and performing rectal in our clinics as well. Well, thank you very much, everyone, for your discussion and your chats. I think this would be a really great opportunity for trainees. Definitely, I think we have lots of opportunity to study this further with a lot of people interested. And so thanks, everyone, for your time today. Have a great rest of your day.
Thanks, Dr. Mulcher. Everyone have a great day.